Hello and welcome. I'm just so excited to welcome everyone back to our third expert forum here at the Pandemic Data Initiative. Today's group, I can't even contain my excitement. I'm so excited about are the sort of data pioneers, the people that were at the root or the center of this practice starting from January 2020 as we have been tracking COVID data and the core kind of asset that has been shaping so much of our public lives, so much of our public policy over the last almost 2 years now. I'm Beth Blauer. I am the lead of the Coronavirus Resource Center's data visualizations and data in partnership with a very diverse team here. I'm also the Associate Vice Provost for Public Sector Innovation at Johns Hopkins University. And in May of 2021, we started this Pandemic Data Initiative as a way to really highlight both the opportunities and the challenges that data presented in the context of COVID tracking. We have been collecting data, as you'll learn more about our efforts, over the past couple of years. And that work has been at the heart of some of the most important public policy and public health information sharing that we've done as an institution. And one of the reasons why we have decided to invest our time in the Pandemic Data Initiative is really to help us inform not only this sort of last mile in COVID, but also as we start to think about what does the future hold, how we can address other health emergencies in future pandemics. We're really very focused on how we can learn from this experience and really apply that learning into the future. So today, we are absolutely thrilled to have three of the most instrumental organizations in COVID tracking from the very beginning of this pandemic, from the very first cases that emerged out of the Wuhan region in China. Johns Hopkins University was at the center of starting to collect that initial data. But very quickly, we found that there were some very critical partners, both in the media and also across the board, that were going to be instrumental in our capacity to not only understand the impact that COVID was having on our daily lives, but also the role that data would play. And so we are very excited to have representation from those first players. But I'm also really excited to be joined by a local reporter. I think local reporting has been some of the most essential core assets to our ability to really understand the way that COVID is playing out in our communities and where we know communities are at the center of pandemic response. And while I have lots of thoughts on all of these topics, let me first introduce our panelists. So that way you can get a sense of why I'm so excited and how we are. But before there, I just want to also remind everyone, please make sure that you add your questions into the chat so that when we get to the Q&A, we have plenty of time to get to those questions. So first and foremost, on our panel is Dr. Lauren Gardner, someone who I feel very fortunate to call friend, but also is the original architect. Lauren had the foresight in January with her colleagues at the Center for Systems Science and Engineering here to develop the very first global COVID-19 tracking map. The JHU map has been at the center of COVID tracking from the very beginning, and still to this day is probably one of the most important global resources that millions of people rely on as they track the pandemic efforts. Our next panelist is Robin Sinmeyer, who is the co-founder of the Atlantic's COVID Tracking Project. The COVID Tracking Project emerged also very early in the pandemic. I had a conversation in February of 2020 with Alexis Madrigal as he was thinking about the role of testing and testing data as it related to COVID tracking. When we started our formal partnership, working with the Atlantic and the COVID Tracking Project as we continued to source data and navigate the treacherous waters that data brought. So Robinson is coming in to represent in the conversation the role that COVID Tracking Project played, which was an all volunteer effort, one of the most amazing resources as at the center of our COVID tracking, and really is the initial staking of the initial efforts into testing and demographic data. In 2020, Bloomberg Businessweek named Meyer and the COVID tracking project team to the Bloomberg 50, a list of the people who define an unprecedented year. And Meyer is also a two-time winner of the Seal Award in environmental journalism. Next, we have Archie Say. Archie comes from the New York Times, and if anyone has spent any time looking at data visualization around COVID, you know that the New York Times has done such an incredible job at really democratizing COVID data. Archie Say has helped marshal the efforts at the Times to deliver a daily suite of visually stunning and highly informative maps, charts, and tables that have bolstered the paper's enlightening on-the-ground daily reporting and expert analysis. The New York Times has been such an integral part of our efforts in COVID tracking, and we are just so delighted that Archie has joined us on the panel. The effort was actually at the center of the Times coverage and won the 2021 Pulitzer Prize for Public Service. And finally, I'm really pleased to introduce Ian Hodgson. Ian has been one of the local reporters into the Tampa Bay Times in Florida, a place where we know pandemic data at best has been polarizing and has juggled various data sources to balance out data coming from the state government in Florida to get trusted information to readers of the Times, of the Tampa Bay Times. And his work not only has appeared there, but it has appeared on Frontline and Univision and many other sources. Ian has also been a support to me as we've navigated the very local questions surrounding COVID data and the local implications of having good or not so great data has on the world. So I just want to thank everyone again. This panel, I can't imagine a better panel to really navigate these questions of the role that our institutions have all collectively had on tracking data. And I thought maybe I would just spend a minute on how we got to this place. And I think this really starts with Dr. Gardner. And I'm so excited to sort of tap her in and have her give us an overview of why it was so critically important to have her work as sort of how it spurred innovation both here at the university, but also globally, as we talked about this emerging role of public data and the application of that data to some of the most critical decision-making that we as society have made over the last almost 2 years now. So I'm going to hand it over to Lauren, and I think that she's got some slides. So please let us give a minute to listen to this sort of what I would consider our origin story here at Hopkins from Dr. Gardner.
Great. Thank you, Beth. Let's see. Go ahead and... All right. Can everyone see the slides? Yes. Can't hear you. Okay, wonderful. Okay, thanks so much for the introduction. It's super exciting to be here with this group, actually, because I am one of many people that have been working really hard at trying to navigate the ropes of these different efforts throughout the last couple of years. And so I'm really excited to hear stories from some other people that have also been pioneering this. But I guess just to get started, I'm Lauren. I'm the Alton and Sandra Cleveland Professor at Johns Hopkins University. I'm a faculty in the Civil and Systems Engineering and Director of the Center for Systems Science Engineering, which is where these mapping efforts start. And so for the last almost 2 years, I've been leading the data collection and visualization efforts behind the global COVID-19 data tracker at Hopkins, which I think most of us are probably familiar with at this point. And in just broad scope, what we're doing is collecting data on cases, deaths, and now vaccines administered for every country in the world that's reported them, which is about 200 countries at varying spatial scales that range from county level up to national level. So all in all, we're pulling in about 10,000 data points for 3,500 point locations on an hourly basis on a rolling 24/7 time horizon. So we're dealing with a lot of data. And what I think we'll get to is the challenges of this process because of the messiness of this data and how we deal with that. And so what I want to briefly try to go through today is the motivation and genesis behind this effort, as well as a bit of the evolution and some of the lessons that we've learned and challenges we've faced. So we started this in January, mid-January of 2020 for a couple different reasons. On one hand, I model emerging infectious diseases. So these are potential new outbreaks, pandemics at the earliest stages where there's a lot of uncertainty, and we do this kind of work so we can understand where they're likely to spread, if they're likely to spread, how many cases really exist, what drives them. And to do this, we need good data. So I recognized this need from the start of the quality, timely, open data for making these kind of policy decisions and mitigation efforts from the start. And then I had a student in Shandong, who's shown here, who was from China, that was very personally invested in understanding these new coronavirus cases that were being reported around the country. And so together, he was already tracking the data from the best sources coming out of China. And so together, we decided to start building out a dynamic data set that we would update daily and share with anyone that wanted access to it, and then build a dashboard to visualize the data alongside it so we could watch and see what was going on. And so really the kind of founding philosophy from the start for this was open data and open science. We did this because we were interested in answering questions about what was going on, and we knew data was integral for that. And we thought there was also other people, particularly I thought my research community, that would also be interested in following this. So the data has been available, and we've been really focused on transparency and making sure that all the data that comes into that dashboard is made public and shared and has lived under an attribution license. The initial stage of the architecture was very simple and very manual. The data was provided in pretty non-traditional sources. There was Twitter posts, Facebook posts by public health agencies and news media that we would collect information, and then some aggregate providers. And so we were collecting this data manually, validating it, and then pushing it through in parallel to a Google Sheets to start with, and then onto the dashboard. So this obviously was not an effort that scaled with what we know happened with the outbreak. We started this, and within a week, we had 1 million hits for the data on the dashboard. Within a month, we had 1 billion. So the scale grew faster than we expected, I guess, to say the least. And this usership was coming from all over the place. So we know it was really relied upon heavily by the media. And so it was, provided as a source for them to educate the public. It was relied upon by policymakers, as we hoped and expected, all the way up to our highest heads of state all over the world, local, state, national level decision makers. But then really critically, it became heavily relied upon by the general public who could access this data directly. It circulated on all the social media platforms. And this was just this, I think, somewhat unexpected, untapped demand for real-time information from day one. And so this was great and a great opportunity, but evolved into much more demands on us for providing accurate and timely information. So to do this, we knew we had to scale up our efforts immediately. And so we expanded our partnership substantially from basically myself and my graduate student to a group that still is much smaller, I think, than everyone would expect for the scale of what we were doing, but amazing people at both Esri and can you see the slides?
We're still on the first slide with the global map. So,
oh, really?
Yeah, it hasn't been advancing, although we're still getting a full picture of. There it goes.
Okay.
There you go.
Well, this is the one I went through first.
Yep.
And this is the one I went through second. And I guess we'll just do it this way. Sorry. So this is the manual effort that I was referring to that we started with, the growth of the outbreak. This is another way to do it. And then here is obviously the usership that I was just referring to and the need to expand these efforts. The need to expand these efforts across a broader team. And so we teamed up with Johns Hopkins Applied Physics Lab, who helped us build out a much more automated and robust data collection infrastructure, with Esri, who was hosting the visualization software that we were using, and with the Sheridan libraries for local hosting infrastructure for the data, and then with the school with many groups across the university, and then the Centers for Civic Impact to build out the Coronavirus Resource Center. And so I can't go into the full evolution of this dashboard in 8 minutes, obviously. So I'm going to jump to what is the current state, which went from a focus on first automating these processes to the extent possible and expanding our source set. So as this outbreak grew from China to other countries and other locales, we obviously had to start collecting data from a much broader set of sources. And to the extent possible, we try to always make these be authoritative government or public health agencies. And then this data is now collected by autonomous collection agents and sent into a comprehensive data curation process. And so we have built out this infrastructure pipeline to be robust and resilient to a lot of the issues that we face with the data quality. And critically, this curation process includes this anomaly detection system, some fusion logic, which helps us deal with errors that would potentially propagate through the system out into the open data products and catching them before that happens. And this data is now what supports the Coronavirus Resource Center efforts, as well as the global dashboard, and then goes into our GitHub repository as an open data product where it can be pulled directly by anyone that wants access to it. This data is now, I think, providing lots of public good, which is great. It's relied upon all over the place. So as we know, it's in the media and relied upon by the media. It helps inform individual decision-making by being integrated into things like Google Maps. It's used by policymakers and is the data that's relied upon for both validating and also building a lot of the models that support the CDC's forecasting efforts. And addition to lots of other research efforts ongoing to better understand what drives COVID. So just kind of to wrap up a couple things, why is this so hard? It's obviously a challenge. Everyone watching this and everyone that's part of this panel knows that this is hard. And I think that the reason is that standards matter, and we're working on these efforts in an environment where there is a huge lack of standards, and this is across lots of different spectrums. So on one hand, there's massive ambiguity in the parameters that are defined that we're trying to collect. And so this is what's a probable case, what's a confirmed case, what's a positive, what's a test positivity rate, what is a recovery. So these variables have been changing in definition over time. They're different from location to location. And when we want to collect data and compare apples to apples, it's really hard. So we do our best to follow the latest CDC guidelines to do this. There's massive instability and inconsistencies in reporting. This is how machine readable are data sets that are provided by different sources. What are the data structures? How is this information sourced? And it also, the structures change over time as well. And so we have to continually adapt to that and be really nimble to change as they change, and also then be able to adapt our infrastructure to read in new formats and new files as they come. There's disturbingly large discrepancies in data from authoritative sources that we regularly have to deal with as well. For instance, one state might say something about a county in that state, and the county says something different about themselves. This is, again, because there's a lack of standardization in what's being reported. And so we have a fusion logic that we've built that can deal with having multiple data points for the same location that we can prioritize and develop logic and processing. And then, of course, we're collecting data on a pandemic. It's being reported by 200 countries. The frequency and time of day reporting is very broad. And so we have to also deal with that. We've pushed hard for the need for data standards, and I think everyone on this panel can empathize with this, but we really need better standards for reporting for all infectious and notifiable diseases. We need this to be at spatial and temporal scales that are granular enough to prove useful so they can be acted on, and the data needs to be made public in a timely manner. And I think last thing that I just, maybe we'll get to this later, but it's something that I get asked a lot, which is why we were able to do this, why we were so successful. And I think this is really important. There's 4 reasons to me that I think come to mind. One is we acted really early. We recognized the value of this kind of data from the start, and we made it available. And I think that this is kind of, because this was available so quickly in the earliest days when it was so important, was why we've been even so successful for the last 2 years. We had a very supportive environment. Funding was available to us from the start through the university and then through philanthropies, which let us continue these efforts uninterrupted. We had technical skills available to us as well. This is not something run by public health experts. This is engineers, computer scientists, software developers, and these are critical capacities and skill sets that need to be integrated into the public health space. And then we also just had the freedom to just make things happen, make executive decisions on in real time on how things should be done, which was obviously something that sometimes resulted in mistakes, but it was a necessary process and learning that allowed us to be so timely in our work. So with that, sorry about the technical difficulties. It's after 2 years of doing all of this technical data collection, we still can't figure some basic things out. But I just want to acknowledge the support that we've had, which is very broad. And I think I'll save questions for later and let the other panelists speak.
Yeah, thank you so much, Lauren. And I'm going to remind everyone, yes, to please add your questions. There's a density of content in Lauren's presentation. And so my job has always been to democratize the way that we talk about the way that data has functioned. And so we have to rely on Lauren, but we are taking questions now. So add them into the chat. Robinson, we're going to tap you in now and invite you to talk a little bit about what happened at the Atlantic and how this work got started. And, first, a huge debt of gratitude to you and all of your colleagues across this incredible effort. And then if you wouldn't mind just giving us a little bit of an overview.
Absolutely. And thank you so much. And thank you for having me. It's great to be in the company of these terrific data pioneers as well. And there's no way we could have done our work without JHU and the work that Lauren was just describing. And so it's just a real pleasure to be here. And thank you for having me. I'm going to talk a little bit about the COVID tracking project, which I started as a means of introduction, or which I was one of several co-founders of, I should say. As a means of introduction, I'm a staff writer at The Atlantic. I don't have significant public health experience, but I'm a climate change reporter. And so in some ways, I feel like was primed to think about global catastrophe and disasters and what was involved in governing them when this started. And it seemed natural that we might have it seemed at least reasonable that we might have a large global catastrophe that was happening without the kind of attention being paid to it that should be paid back in March 2020. On the other hand, I really am just, first of all, one of several co-founders of the COVID tracking project, and therefore did not have a total view into it, and also not a public health expert, not even a data expert, just really a journalist. And so I'm going to try to bring my perspective to this and bring what we learned to this event. But there's many parts of this of this problem that I would say go beyond our expertise, go beyond my expertise. So the COVID tracking project was founded in March 2020. From March 2020 to March 2021, we tracked tests, cases, current hospitalizations, and deaths across all 50 states and US territories and districts and so on. We focused on state level data, though we did collect some city level data. We did not really publish it. We just used it for internal analysis purposes. I think our big innovation was, or that we were the first group to track negative tests, which was quite a big deal in March 2020 and became a signal with varying degrees of information as the pandemic went on. We were used, the COVID tracking project data was collected entirely by volunteers to whom I'm extremely grateful and who did incredible work. Basically every day we collected data from March 7th to March 7th. Our data was used in more than 1,000 academic papers. It was cited by the Biden administration and the Trump administration. And it was cited by lawmakers in more than 11 papers, in more than 11 letters to various public health agencies. The COVID tracking project emerged, man, we're stuck, but that's fine. Lauren's slides, you saw many of them in a clump. You just saw many of my slides. I can't figure out how to go back. I'm just going to roll with it. The COVID tracking project was founded in a moment of pretty profound anxiety by my co-founder Alexis Madrigal and I. There was this moment in March 2020, many people will remember, where it was completely unclear how many negative tests had been run around the country. We heard that tests were going out, but in the news, we would hear about positive cases. This is when the first few community cases were being published and described in the United States. But it was very unclear what the actual dragnet of negative tests were. And so in that first week of March 2020, Alexis and I, basically out of fear and anxiety, resolved to just kind of brute force this in a classically journalistic way and contact all 50 states and just ask their public health departments how many tests they could run per day and how many tests they had run. And within about 18 hours, we got enough information back to discover that the US by that point, by March 7th or March 8th, 2020, had actually only run about 1,800 tests that we could confirm. I think we now know that number was a little low. It was probably in the 2000s. But if you remember, at this point, we were a week into the US community pandemic. And it was pretty shocking that the US had only run several thousand tests. We continued through the rest of the pandemic. We what happened is we created this project that took volunteer effort, and just volunteers kept showing up. And then what started as a kind of emergency tracking project for just a week or two, we realized was going to become a larger project that would continue at least until the CDC was ready to track tests, which we thought might happen in April or May. When the CDC began publishing data in those months, we realized it just didn't line up with our data, and it seemed to have some internal problems due largely to the same kind of standardization issues that Lauren just talked about. And we actually kept going. And we kept going until March 2021, as I've said. There's a few things we learned during this effort that I think are important lessons to bring to the overall way of thinking about data that we pioneered at COVID Tracking Project. The first is that just the sheer number of standardization problems in data really required us to track, first of all, by hand across all 50 states. And it required us to get into understanding how the data are created. I think there's a sense in popular culture and how these topics are discussed that data just kind of exists. As we all know, data is actually created. It's created by either someone entering test results into a computer or an automated process or a state representing the data that it gets from its hospitals in a certain way. That data is like profoundly made. And not only does it reflect differences in standardization, but it reflects differences in how you count and how individual tests are counted by states. And you have to understand the way that data is created in order to understand how to interpret it. The second is that data is just another type of information. One interesting thing about the COVID Tracking Project is that my co-founders, Alexis Madrigal and Aaron Kassane, and I, especially, I think, are all quite skeptical of data. We actually all have science and technology studies backgrounds and have written a lot about the peril of big data. So it was funny for us to be running a data project. But I think one thing that seeing the construction of the data up close and really looking at all 50 states' data every day, either indirectly through volunteers or just through the kind of daily data collection process that we ran. One thing that it convinced us is that you can't just fully, the data will tell you a story, but you have to understand how each of the variables work. So one of the key insights that we found during last summer that kind of continued through the end of our data collection period was that hospitalizations, as collected by the HHS, were actually the most reliable and fastest form of data. So it takes time for a positive case, or a negative test result to make their way through the system, while hospitalization basically shows up on the day that someone is admitted. What we discovered is that even though everyone, cases are very important, they're a useful data set in some senses, but at least during the height of the pandemic, it was hospitalizations that were the leading indicator. And you couldn't really look at cases to see where a place was surging. You had to look at hospitalizations. I think what I would stress, and what I think we learned from COVID, from CTP, is that you have to, if we had better data standards, you could automate a lot of the process. And as Johns Hopkins has done, has shown you can. If you're governing a country, if you're responsible for interpreting data to make governance decisions, though, you have to have kind of your hands in the data every day. And if you're making decisions, it really helps be talking to someone who has their hands in the data every day and understands how that data is constructed. The early pandemic example here would be tests. If you don't know how many tests are being run nationwide, the case data is not useful. The later pandemic example would be the cases and hospitalizations trade-off that I just described. I think what CTP convinced me that we need is, at the highest level, to have folks looking at and interpreting this data on their own and understanding how the data is made. So we can get into the limitations of CTP in a second, but I think one thing I would love to see, or one institution that I think could be quite helpful for future pandemics and future situations like this, is concentrating some of this expertise and some of this data collection and curation within the White House or the very top of an agency, because you really need people who understand the limitations of the data to be able to describe what's actually happening in the data to people making decisions. Likewise, just as Lauren said, the freedom to make executive decisions in real time is extremely important when doing this kind of work, and when deciding, for instance, how to interpret and code like Arkansas's test data on a certain day, when we have strong reason to suspect that it's made some kind of error and we want to correct for that. You basically need the ability to make executive decisions and make data for governance and interpreter users, and that kind of capacity is really important. No, and that's the end of it. And where CTP was more limited, I think, and looking back at it now from 6 months later, we never had problems attracting funding or any of the kind of hard budget constraints or hard institutional constraints that might seem to have imperiled us. Where we ran into issues were that we were a volunteer project, and we were able to pay many people as the pandemic got on. We had funding for that, but we just had people who were running data processes, who understood all this data extremely carefully, were basically doing it either on sabbatical from their real job, or while also holding down another job. And just the human limits of having folks who were in the data every other day or every day for 12 months, not doing when it wasn't their job, when they cared incredibly strongly about the quality of the data. And when it seemed like the government was about to take over many of these capacities, this got to be too much. And it was never a funding issue. People ask why we shut down. It was never a funding issue. It was always our volunteers were very tired. It was extremely work intensive, and we believed that this kind of work was best done by the government, and that at a certain point we shouldn't be a crutch for the government anymore. I'm excited to take questions. At the end, I would say, wrapping up, what was quite important for us and what made us different, I think, was that volunteer hands-on approach to data, having people interpret the data every time. Obviously, that would not work in a global context like Johns Hopkins data tracker does it. However, I think for people who are making decisions for governance or advising entities going, or in a journalistic capacity, writing for a single polity, that kind of hands-on understanding of the data is extremely important. So I look forward to questions, and thank you so much for having me.
Yeah, thank you so much, Robinson, for joining us. I'm going to hand it directly over to Archie to make sure that we make it through our presentations and afford time for questions. So Archie, I am just such a huge fan of the work that you've been leading at the New York Times. Thank you again for being here. And I can't wait to hear you talk about why the Times went all in such a impressive scale.
Thanks so much, Beth. So we started tracking cases in January 2020 with 2 graphics editors reading press releases and listening to press conferences from local health agencies across China. At that early point in the pandemic, we could still show every individual case as its own symbol on the map. So I just wanted to show this remark how far we've come. But as the pandemic spread to other countries in the region and around the world, the global tracking effort quickly became much more than we could take on. And so we were really thankful and relieved to see that Johns Hopkins had started compiling and publishing data by country. At around the same time, Mitch Smith, one of our national correspondents, had started tracking US cases in a Google spreadsheet. And you can see here in these early rows that we were trying to capture each person's age and gender, as well as some details on the condition and how they contracted the virus. The effort was painstaking and required listening to press conferences, combing through press releases to gather details on each case. Our tracking effort expanded to more reporters, and then we started hiring college journalists and freelance reporters to help with the data gathering. And at the beginning of March, we launched our US tracking page at a time when the cases numbered only in the dozens. Here's a case curve when we launched the page. We were entering about 20 cases a day at that point, but it wouldn't look like this for long. In a week, we were entering 400 cases a day, and in another week, it was 2,400 cases, and in another week, it was 10,000 cases a day. So the Google spreadsheet was beginning to strain, and it finally stopped working at the end of March, just as we passed 43,000 rows, and we had more than a dozen people entering data in it at the same time. And at that point in the pandemic, we were really no longer able to keep track of the demographic details on the cases. Luckily, we'd seen the writing on the wall for the spreadsheet a few weeks earlier and had already begun an effort to build a proper database to manage all the numbers and to try to programmatically pull in data where it might be available. We started with the metadata collection effort to see what state and local officials were posting on websites. As you can see from our spreadsheet here from March 15th, the availability of county data was spotty. Some states did not report county data, so we had to reach out to individual counties. And some of that county data could be programmatically collected, but most of it had to be done with journalists reporting out the data from each county every day and entering it by hand into spreadsheets. And even when data was available, it was being published in all different formats, from HTML tables to text and sentence form to Word documents, posted for download. It was a real mess. The types of data published by each state varied widely, and whether they reported the data by county was also variable. And there were several different ways states were defining what they counted as a case. And so one of our biggest challenges was making sure that we collected the data that we collected was as consistently defined as possible. This sometimes meant asking officials to provide us with the specific data that met our definitions instead of just the figures that they were releasing publicly. In those initial weeks of the pandemic, we discovered that we were the only organization continuously tracking US case and death counts at the county level from the beginning. Scientists, as well as federal, state, and local officials, began asking us for a county data set because there was no other source for it. I had been expecting the CDC and some other federal government agency to step in and become the official clearinghouse for US COVID data, but it wasn't actually until the end of 2020, about 10 months later, before we began to get useful COVID data from the government. Instead, a number of groups stepped in to fill the void, like Johns Hopkins, the COVID Tracking Project, the Marshall Project, and 1.3 Acres, just to name a few. Over the next year, our county data collection efforts slowly shifted from manual human data collection to more programmatic methods. State and county health officials moved from simple web presentations to more sophisticated dashboards. Unfortunately, many of the dashboards were only meant to display data and not to share it. So a big challenge was reverse engineering those sites so we could programmatically collect the data. And the websites were frequently changing as officials decided to add or alter what they displayed, which caused our programs to frequently break. So even the programmatic effort required a team of people working 18 hours a day, 7 days a week to keep all the computer scripts operational. The size of our tracking effort grew with the pandemic, and at its peak, the newsroom had almost 80 people actively working on the project each week. And many of these people were working extremely long hours, sometimes 7 days a week for months. I was just so moved by the dedication of everyone on the project. Throughout the pandemic, there were numerous subjects where our only insight was gained through manual data collection efforts. The government had released data on nursing home COVID deaths, but it was full of duplications and errors that made it impossible to draw reliable conclusions. Our data team had been tracking nursing homes from the beginning of the pandemic, and on May 9th, 2020, we were able to report that a third of the US COVID deaths to that point were nursing home residents or workers, an important revelation early in the pandemic about how disproportionately COVID was affecting the elderly. We also tracked cases in prisons and college campuses using the same manual data collection techniques. Many institutions would not voluntarily report their case data to us, so we had to file many public records requests. Over the course of the pandemic so far, we have filed at least 700 public records requests as part of our data collection effort. It isn't our usual practice to become a raw data source, so this project was definitely a departure for the newsroom. But it was clear as the pandemic unfolded that there was a huge vacuum for reliable data to help people navigate the crisis, and scientists and officials needed the data to help formulate policy. I'm really honored to be here with some of the groups that helped fill that void. Thanks, Beth.
Thank you so much, Archie. All right, Ian, I'm going to tap you in. So Ian and I have had a series of conversations over the last 18 months, some existential, some very deliberate, some really kind of advancing the field. But Ian's been doing some very critical reporting in a place that has had a kind of storied relationship to COVID data in Florida. And so I want to hand it over to you, Ian. I'm so glad that you've joined us. I think this local perspective is really going to be one of the most formidable components of the story when we look back on COVID, is that, you know, COVID was such a community spread disease. and community papers and local journalism played such a critical role. And so I would love to hear from you, hear your perspective. And so I'm gonna hand it over to you, Ian, to wrap us up in these panel discussions. But again, we're gonna, as soon as you're done, we already have a lot of questions, and so we want to make sure that we leave some time for that as well.
Great, thank you so much, Beth. If I can get my slides up, thank you. So I'm going to talk a little bit about Florida's COVID data, where we started and where we're at now. So starting in April 25th, 2020, the state provided daily updates with county level infections, hospitalizations, and death rates, cross-section with ethnicity, race, and age. The state ran a COVID tracking website with an API that you could pull data from. And the COVID tracking project actually gave Florida an A for its data effort. If this daily reporting wasn't enough, the state also released case line list data, which gave us anonymized data on each and every case that popped up in the state. We also got a plethora of other data, including cases and deaths at long-term care facilities and assisted living facilities, prisoner and guard infections at Florida jails, and cases for student, faculty, and staff at elementary, secondary, and post-secondary schools across Florida. I should note that a lot of these supplemental data sets often took the threat of legal action to get, but in the end, we were successfully able to get Florida to hand over this data to help our reporting. Then on June 3rd, 2021, we learned that the state would no longer be presenting this daily data, and it was going to shut down its online COVID dashboard. And the line that we got from the spokesperson for Governor Ron DeSantis was that we were entering a new phase of the pandemic, and this quality of data wouldn't be necessary anymore. Unfortunately, she was right, but I think for the wrong reasons. So when that decision was made, we were reaching about 12,000 infections per week. That number doubled in less than 1 month and was 10 times higher just 2 months later. But throughout this period, the state kept on telling us that this data, the return to daily data, the return to detailed county level data wasn't in the public interest. So a little bit of background about Florida's transparency law. We typically have amazing transparency law in this state. Health data is one exception, that it's confidential and only made public when necessary to public health. At the moment, it's only the Florida Department of Health and the Attorney General of the state who decide what is necessary to public health. I should say Surgeon General of the state. And they've consistently cited this example when we've asked for new data or return to the type of data that we had previously. There's currently a case going through Florida courts, Smith versus the Department of Health, that's asking courts to reconsider who gets to actually decide what is necessary to public health. So now this is what we get for each county in Florida. It's a single line in a spreadsheet that's put out on Fridays, usually at about 5:30 p.m. You know, it's way too late to give anybody a call. I think the experts that I've been reaching out to have, all sort of been like, hey man, I'm about to sit down for dinner. Like, please stop bugging me with questions at like 6 p.m. Whether or not this is an intentional thing to give us data at, Friday at 5:30 when everyone's wrapping up, I can't speak to that, but it is an inconvenient time to say the least. We also no longer have access to the COVID dashboard and the API that went with it. We no longer get school, long-term care, correctional facilities data. And we no longer get the extensive county level data. Typically for this stuff, we're being pointed to federal government resources like the CDC, but there are discrepancies with how the CDC and state report even the even the data points that overlap between the two sources. And there's just been general confusion over daily case and death tallies. So the application of the exemption ever since June 3rd, 2021 has been kind of inconsistent. We've successfully been able to get the state to give us county-level variant reports, but they won't give us breakthrough data, they won't give us the restored dashboard, they won't give us case line data, and they won't give us comprehensive institutional data. And we found that the state keeps on sending us to the CDC whenever we have questions, but state and federal agencies seem to have a communication problem. This is just one example from August of this year. In a single day, the CDC reported that there were 28,000 new cases in a single day. What had actually happened was that the CDC had divided cases over the weekend from Friday, Saturday, and Sunday by 2 instead of 3. The actual number was close to 19,000. And this was an example where a lot of Florida papers included this number in their headlines, and the Florida Department of Health, sort of got on Twitter and smacked us all down, saying, this number that you're all reporting is actually wrong. Another example is county level deaths. So on June 4th, the same day that Florida's COVID dashboard went offline, deaths by county reported by the CDC went to 0. And we asked the Florida Department of Health repeatedly, like, hey, can you give us death data? Because what we're seeing from the CDC doesn't make sense. They repeatedly sent us back to the CDC saying that they were providing the data, but CDC wasn't presenting it. Eventually, the CDC responded and said, well, Florida's not presenting this data that we need to pull deaths from. And that turned out not to be true. We actually got the receipts from the Florida Department of Health showing that they had been sending daily data that could be used to calculate county-level deaths. It turns out that when the CDC and Florida Department of Health eventually met to discuss the problem on September 1st, CDC said that they had been scraping data from the Florida Department of Health COVID tracking website and not using the data that the Florida Department of Health had been providing without telling the Florida Department of Health. On September 12th, the data was restored, but there was a huge error, and it took almost a week to finally resolve. And just, some context of what's been happening. The pandemic is happening in a context when staff at the Florida Department of Health is at an all-time low. Since Governor Rick Scott took office in 2011, staffing has gone from 17,000 down to about 12,000 now. We also have the fewest staff per capita, or among the fewest staff per capita in the country, and among the lowest pay for Florida Department of Health workers. And one takeaway from this is that one news outlet just can't take this on alone. From the legal action that we've had to take to the Florida Department of Health and sharing knowledge and best practices, it's been a combined effort of not only Florida newspapers, but national newspapers. And one of the reasons I'm so excited to be on this panel is we've relied on resources from COVID Tracking Project, Johns Hopkins, and the New York Times in order to be able to effectively hold the state accountable. And finally, I just want to give a shout out to my other colleagues here who've been doing critical work tracking COVID, Kirby Wilson, Langston Taylor, and Allison Ross, who all gave me amazing input and comments on my presentation. And I think we're going to questions now. Thank you.
Yeah, so we have just a couple minutes left. I want to make sure that we get to at least some of the big questions. And I think I'm going to distill some of the ones that have come in. Thank you to everyone who has submitted questions. I think the biggest one that we're seeing, and one that we keep on hearing also, is is there an off-ramp? Are we going to actually be able to use the data to help us really answer this larger question of when is this moment where we shift it, not scientifically from pandemic to endemic, but when do we think that the intensity around collection, and we know that CTP made this decision in last March, but what do we think generally is the demand waning? Is there COVID fatigue also setting in your reporting? And do you see a role of data actually being playing in sort of justifying this kind of shift from pandemic focus into the more sustained endemic approach to handling COVID in communities? And I'd love, Archie, to start with you to think about the role of data and also the kind of where the New York Times is on this one, especially.
Yeah, I think we really saw, like, one of the big challenges, I think, is just the lack of standardization across all the different data sources. And I spoke to, like, many of our reporters, like, who've been working on this subject, like, over the past year, about a year and a half. And I think the big challenge is that the federal government has limited ability to mandate standards to the states. And like, I think in a national crisis like this, I think we saw the need for data at a national level, that is detailed to help the public navigate the crisis. And there might be a place for a movement to, like, standardize how we report how health data is reported, so that if we face another crisis like the COVID pandemic, we are able to mobilize and have the data more quickly available to people who need that data to make decisions.
Agree. One of the things that I think also that is probably top of mind for all of us is this notion of the role that data played around misinformation, and how our data collectively was used in really interesting ways to contextualize positions on where the pandemic was and the impact it was having in communities. What are aside from the standards, which I think we're all kind of violently agreeing are required, are there other ways that we can think about misinformation and the role that we have played as kind of a central provider of information to kind of diminish the effects that misinformation has had on communities? And I'd love to Robinson hear from you on this one.
Yeah, absolutely. It's funny. I think we did think a fair amount about this at CDP. There's two. To some degree, this is like all journalism. If you publish information that's then misused, you can inoculate against that somewhat by acting in good faith, by communicating extremely clearly. But to some degree, there's a limit here, and you have to continue publishing correct information in good faith and hope that eventually people come around and try to, deal with the societal structural problems that lead to misinformation. However, to actually answer your question, I mean, we thought about doing this in two ways. The first is we published every week and every day on our Twitter account very clear interpretations of the data that we were publishing that would, at times, directly rebut kind of what we felt were misinterpretations of the data, or ways that the data was being misused, or arguments that were being made about the data, not necessarily our data, but just cases generally or something in the discourse. And we would just respond to that and reveal in our work why we thought that was not accurate or misleading. That was always done in a context of extreme awareness of how our politics and political assumptions that we made would be interpreted by our readership. And so we were basically always trying to write for an audience that was, maybe much more suspicious of data, much more suspicious of the government than our audience actually was. We were always trying to write in such a way where perhaps friendly state official could give or a friendly state employee could give a document, a memo, a blog post that we wrote to an official who might be skeptical of pandemic policy overall, and not have them react to it in a strong way, just kind of see that what we were doing was clearly presenting information. And so I think those two tracks, like clearly interpreting our own data and making interpretation part of the overall product and part of the presentation of data, and second, making sure we didn't embed certain views or languages or assumptions that could alienate parts of our audience in our own reporting and in our own writing, that just there's a place for that, but our role was to be kind of honest brokers as best we could.
All right. Well, I wish that we had an abundance of time, which we do not have. So I unfortunately have to wrap it up here. Although I could talk to all of you for hours. I think there's a follow-up conversation that should be had amongst us because there are huge opportunities to learn from this. So I want to thank everyone for joining us. As always, we'll have a recording of this session on the site with the compendium of materials. You should be able to also link to the next forum. And have the opportunity to also click into the Pandemic Data Initiative and the rest of the rich resources on the CRC. I want to thank everyone again for being here, and also thank you for your dedication, your sleepless nights, and your doggedness as we've navigated, I think, one of the most exceptional moments in our collective history. So I thank you all, and I hope to talk to you all again very soon. So thank you very much. And thank you to all of you who have joined us and submitted questions. We really appreciate it.